What we need is not more medication, but more education, because the best prescription is knowledge. This is Exposé coming to you live from Lagos, Nigeria, every Monday on Instagram, YouTube, and Facebook simultaneously. I'm the regular host, Tony Akinyemi. Don't forget, what we need is not more medication, but more education, because the best prescription is knowledge.
Right. Hello and welcome to Exposé with Tony Akinyemi, where we share wellness information for your health transformation. Don't forget that what we need is not more medication, but more education. We believe that when people are informed, they're able to make informed decisions and informed choices. The right kind of information can actually bring positive transformation. And when we are uninformed, we are actually deformed. So when you have access to the right kind of information, it helps you to prosecute life properly. You don't make costly mistakes, irretrievable mistakes. Now, we offer information in the area of wellness in particular, and that encompasses every aspect of our family lives. And so in this particular season, we've been talking about fertility, infertility in men, in women, and what have you. In Africa in particular, you know that having babies, families giving birth to children is a big deal. And when the couple get married and they're not able to have children, it's always a big challenge. And that's why we've given all the pieces of information that we have shared so far in this series. And I promised you that at some point, I'll be bringing those who know better than I do, those who are professionals, who are experts, who are experienced, who are well-trained and well-certified, to be able to shed more light on some gray areas and give some expert opinions. And we're honored today to have one of them on the platform, who is an MD, a medical doctor, a consultant gynecologist and obstetrician, and with a wealth of experience in that field. And so she'll be dealing with all the questions regarding particularly maternal mortality in particular. And then maybe some other digressions here and there to deal with accessory questions that may arise along the way. Now, when people are eager to have children, it's a good thing when their prayers are answered and the woman gets pregnant, and then everybody's happy, everybody's rejoicing. Oh, wow, in the next 9 months, we're going to welcome a new addition to our family and what have you. And then, in some cases, the very day comes, and then disaster strikes. And maybe the woman dies in the process of childbirth. So all the anticipation, all the expectation, all the joy, everything just fizzles out, and it becomes a complete turnaround for the bad. And now it is mourning and weeping and crying. We don't pray that that becomes anyone's experience. And that's why we need to preempt. And that's why we need to be equipped and be armed with necessary technical information, relevant information, to prevent such things. In this part of the world, we like to always mystify everything, and we try to put everything at the doorstep of witches and wizards and what have you. And there are some basic things we just need to know to prevent some of these disasters from happening. And I think today we are in a very good position to be well educated, well informed, and well equipped with the necessary information that we need. We have on set today on Exposé with Tony Akinyemi a dear friend, a dear sister. She's the wife of my very good friend, and she herself in her own right is my very good friend. I've known both of them for so long, back in the day when we were all students on campus, even before they got married. And so today I'm honored to have with you Dr. Florence Kemi, the wife of Akindele. Welcome to Exposé with Tony Akinyemi.
Thank you so much.
It's good to have you here. And, viewers, we are doing this via Zoom so that, she lives in Canada, I live in Nigeria, and we want to get this done. So if there are, little glitches here and there, just understand that we're doing this interview via Zoom. and that's okay. I hope everything goes well. So once again, Dr. Akindele, you are very welcome, and we thank you for finding the time to be with us on Exposé in spite of your very busy schedule. Now, we want to meet you first and foremost. We want our viewers to know, who is Dr. Kemi Akindele? What is her background? What authority does she have to speak to this issue? So please tell us a little bit about yourself, your background, your training, your route from the day you were born till today. Right.
Thank you so much. I graduated 1991 medical school, Obafemi Awolowo University, and
that's the school. That's the school. Yeah, that's the school.
that's great effect. All right, so 1991 graduate of the medical school, Obafemi Awolowo University, and then I had my residency in the University College Hospital in Ibadan in obstetrics and gynae. And after that, we moved out of the country. I then went for a master's degree in public health in the University of the Witwatersrand in Johannesburg, and got that in 2005. And since then, I mean, right from the time of residency up till now, I still practice obstetrics and gynecology. So I've done that in 4 different countries now, starting from Nigeria to Swaziland to South Africa, and now here in Canada. I often joke that so where I am in Canada, I practice everything from the normal, we call them natural delivery, to cesarean sections. I do all that a lot. And people here were the first people to start asking me about how many babies have you ever delivered? Nobody had ever asked me before I came to Canada. And so in Canada, I started counting. I said, okay, because it was such a frequently asked questions, I would love to tell them, and this is how much I've done in where I am in Canada. And so I started counting. When I got to 1,000, that would be in 2017, 16. I got to 1,000, I stopped counting. Then people started asking again. So now I'm quite close to 2,000 if I've not hit it yet. And that's babies that I delivered by myself where I practice in Canada right now. So before then, of course, so much more, both in Nigeria, Swaziland, South Africa. Southern Africa actually has quite a large number of women delivering at the time we were there. So if I combine everything, I will talk about thousands of babies delivered. My passion had always been about women's health. I love to see the total well-being of women, spiritually, physically, mentally, everything. I believe I have a calling in that direction, and that's where my training also took me. Well, God allowed me to be trained in that direction. So either way, when you talk of either the clinical aspect or the policy or overview aspect, I had a lot of that in the public health training that I got. Actually, I went into public health training because I wasn't satisfied with the number of women I could help as a clinician, because that was more one-on-one. I wanted to see what things could be done as an overview to help. And so here I am. I'm still bubbling. I still had a baby yesterday. Still added another one. So I have that unique experience. I believe that God gave me that. All right. So yes.
That's amazing. That's amazing. So it would be right to refer to you as the mother of 1 million babies.
I guess. Plus, I'm a mother myself. I'm a mother of 4, a grandmother of 6.
Wow,
and
thank you very much for all of that, for what you do. So your practice is currently in Canada, in North America. And you are still involved in gynecology and obstetrics and what have you. And now public health dimension has come into it, so that you can also influence policy and give pieces of advice that can help policymakers and what have you at the end of the day. Thank you very much. Now, I want us to go straight into the real focus of our conversation today, and that is maternal mortality. I have heard people who lost their wives in the process of childbirth, and then they started regretting, oh, if only we didn't even go for this baby. and I still have my wife by my side. You know, such statements can really, really be very, very emotional, you know, emotion filled when people say, I wish we didn't try to have a baby so that at least my wife could be by my side. You know, in the process of trying to have a baby, sometimes they lose the baby, they lose their wives at the same time. Now, what exactly is maternal mortality? We want you to break it down in very simple terms, because all of us here on this other side, we are laymen, you are the experts. Let us understand what maternal mortality is all about, and if there are different types and different aspects and different categories, let us know.
So maternal mortality is the death of a woman who is pregnant, and while she's pregnant or anytime within 6 weeks after delivery. If she dies from any other cause that is not pregnancy related, we call those incidental causes, and we don't count that as part of the definition of maternal mortality. For instance, if a woman who is pregnant dies in a motor vehicle accident, that is not, strictly speaking, maternal mortality. It's one of the incidental causes. And so that's how we define maternal deaths.
So it has to do with, it has to be pregnancy related. The death has to be pregnancy related.
Yes, so it has to be pregnancy related or a condition that is aggravated by pregnancy. For instance, if a woman had hypertension before getting pregnant, that is not, you know, it's not pregnancy induced, but we know that with hypertension, there can be additional complications that could lead to the death of the woman. And so that is part of maternal mortality.
All right, so if I got it clear, a woman is pregnant, and then the pregnancy induced certain medical conditions, complications that led to the death of the woman before childbirth, during childbirth, or up to 6 weeks after childbirth.
Correct.
Or the person actually had an underlying medical condition before getting pregnant, and then pregnancy now came in to aggravate that medical condition and now led to her death. That's also part of it. Right.
Yes.
I'm a good student. I'm a good student. All right. So now let's look at some statistics. What is it like? What is it like? This maternal mortality menace. What is it like globally? What is it like, let's say, in sub-Saharan Africa, for example? And then we zero into Nigeria as a country. Can you help us scale it that way? Looking at it globally, what are the statistics globally? What is it like in sub-Saharan Africa? And in Nigeria, where I am particularly, specifically interested in the statistics for this country, Nigeria.
Yeah, so globally, maternal mortality trends have been that, you know, in the 60s, before the 60s, it would be really high in countries like the UK, the US, and then they focused on preventing, you know, what would cause maternal death, because most of these things are preventable. So globally, maternal mortality ratio or rates, because we count the number of women that die per 100,000 live births. So if we have 100,000 live births, we're going to compare that with how many women died in that process. And so in the world, we know for sure that developing countries, particularly sub-Saharan countries, have been the worst hit. And this is because maternal deaths are directly linked to socio-economic factors. That's been demonstrated by research all over the world. There are social determinants of health. So what would be the cause of death in a place like Nigeria will be many factors relating from access to care, starting from the woman not even knowing what she needs to know. She's not healthy before pregnancy. Okay, maybe we shouldn't go into that. Let's do the statistics. So sub-Saharan Africa is really a big hit. And so other developing, or call them poor nations, and then nations where there's war. I mean, obviously, where there's war, there's not only incidental causes, it's also that there's no access to care, no access to food, and all those stuff. So you talk of very high rates in places like Afghanistan and all that. Now, the problem with developing countries and with the healthcare systems we have, I remember back in the days, even in Nigeria then, we didn't really have what I would call correct statistics. There's no notification. So until we notify and say this is it, there's always an estimate. So it's been estimated anything from 850 to 1,000 baths per 100,000 live baths. It's one of the highest in the world. Now, you compare that with Canada, where I practice, it's 10. So it's 10 per 100,000 live baths compared to 850 to 1,000 live baths. In the US, it is more of like 17, hovering around 17 per 100,000 baths. And the interesting thing again there is that more Black women die in the US than their Caucasian counterparts, given the same conditions that they live in the same country. So we see a lot of social determinants coming in when it comes to maternal health and maternal mortality. So that's kind of like an overview of the statistics. In Canada, the Black women are now agitating to say we need to know. So before, there wasn't any major statistical focus on Black women in Canada. So we have 10 for everybody. There's nothing about the Black women. Yeah, but in the US, there are specifics to show that more Black women die than their Caucasian counterparts.
So obviously, the social status, the economic status of families is a very big determinant of maternal mortality. Since in the US, there is a differential even between the Caucasians and the African Americans. And I think apart from skin color that is different, the other thing that is different is the economic status. Yeah, so I personally don't think, and I know you probably would agree with me, that their skin color didn't have anything to do with that.
No, I said that the only thing I think of that may be genetically related is the fact that with the toxemia of pregnancy, so toxemia of pregnancy, anything hypertension related, preeclampsia, just seem to be common amongst the Black race. And, you know, it's interesting. Even, I mean, a woman died not too long ago in the US. She was a doctor. She was given all the attention necessary. She was cared for in the hospital where she worked, given all the preferential treatment, if you want to call it that way, and she still died. And so if you look at statistics, there's just something about preeclampsia in particular that is more common or is more severe, say, because even in the Caucasian, when it happens, it goes so fast. If it's going to happen, it could go so fast that you almost be, you know, not be able to do anything. So that's the one interesting thing that I know that maybe with more studies, we will come to understand what's going on, but that's one thing that stands clear out.
Okay. Yeah, those figures you reeled out are a little bit scary, you know, particularly in relation to Africa and Nigeria. I just took some notes here, and if I got you right, in Nigeria, out of 100,000 live births, or 100,000 live births, we have between 850 and 1,000 maternal deaths. Is that correct? Between 850 people, 850 mothers and 1,000 mothers will die among 100,000 that give birth. And whereas in Canada, where you live, it's only 10 of them that will die out of 100,000. I mean, that is scary. That's times 100 of the number of people that die during childbirth or that experience maternal birth in Canada, times 85 to times 100 in Nigeria. Now, you have identified genetics and economic factors. What other factors do you think have accounted for this very wide disparity between Canada and Nigeria, for example?
so the factors can be divided into three so that it's clear. It will be the primary ones where we're talking of a woman in Nigeria. And maybe it's better to relate it with stories, then it becomes more vivid. So there's this young girl who didn't go to school, who didn't eat well, is anemic before pregnancy, got married off age 16, and doesn't eat well during pregnancy. Access to care, the hospital that would care for her is like maybe 100 kilometers away from where she lives. There's a bridge, there are weather conditions. And so majority, and that's why we honestly really don't know the figures in Nigeria. Some of these women don't even come out at all. Like they don't get to hospital. And then they die at home because they would deliver at home under supervision of people who are not trained well. So that is one primary issue. It's the access. It's the background health of the girl child that is not taken care of. And so that is under primary. Under primary, you will still say, even if the person who lives in Lagos, for instance, there are so many hospitals around in Lagos, but she doesn't have access because she has to pay. She doesn't have access because, she just doesn't know that anything is even wrong with her. So those are primary things that I think that knowledge, just pouring out as much knowledge as possible to women should start taking care of those things. Because even if you did the best of the best teaching hospitals and very big, some people are not coming there. In fact, most people won't come there. They don't have the access. So that is very real. Now, the secondary factors will be, are there even healthcare centers around? Are there trained people? And how many people do we have that can wade into the problem? Should there be a problem with a woman? So there are the problems of the woman and family and nutrition itself. There is a problem of availability of resources in terms of just simple enough people taking care of pregnant women and doing deliveries. And then finally, there's the aspect of being able to take care of the ultra specialist kind of thing, which would come down on one woman at a time. So it's from primary to secondary to tertiary. And those are all big ones that we can talk for weeks about when it comes to comparing Canada and Nigeria, for instance.
Well, so we can now see how the structure and the setting of a nation actually impacts on every aspect of life expectancy, maternal mortality, even infant mortality, and many, many other quality of life and what have you. So that will mean that when people are voting during elections, they should really think deeply before they vote, before they cast their votes, because they are actually choosing the quality of life that they want for tomorrow as they vote candidates into offices. Anyway, we are not talking politics today, but we can now see how differences in the political setting, the economic situation, and the leadership of nations have implications for every aspect of the lives of the citizens at the end of the day. We are going to go on a very short break right now, and when we come back, we will resume this conversation. So, viewers, please don't go away. This is Exposé with Tony Akinyemi, and we're talking maternal mortality with Dr. Kemi Akindele. We'll be back very shortly.
You said you are going to do this and this and this through my life. They are not yet done, so it's not time. And the sickness that seems was going to kill me will just disappear. But if you do not engage your assignment, what will you tell God?
So the things you do triggers off something in heaven, and God responds to the things you do.
So there are things that if God forgets, he becomes unrighteous. And God says, look, I'm too holy to become unrighteous.
Welcome back. This is Exposé with Tony Akinyemi. We've been having a very, very wonderful conversation around maternal mortality, and no one else other than one who is the mother of 1 million babies, I would say. She has delivered so many babies in Africa, in North America, as a gynecologist. And she's also a public health physician, in addition to being a consultant gynecologist obstetrician. So she's been talking to us about maternal mortality, reeling out very, very worrisome statistics, particularly in sub-Saharan Africa, relative to first world countries. And we want to dive into another aspect of this whole conversation. What are the factors responsible for maternal death? What are the things, the principal factors in particular, that make women lose their lives in the process of making babies? Can you please shed light on that for us?
Sure. So when it comes to the causes, we talk of the 5 major causes. I mean, there are others. And the first one, if I go by not the degree of severity or numbers, but just to start talking, okay. I talk from abortion-related causes. So abortion-related causes is one of the big ones, either from that spontaneous miscarriage, or what we call miscarriage, or from therapeutic abortions, or for attempts to abort, or also under that category, I would put ectopic pregnancy. So pregnancies that would happen outside of the uterus, where the mother just bleeds to death from rupture of ectopic pregnancy and all that. So that's one category. The other one would be maternal mortality from hemorrhage. So usually we call it primary postpartum hemorrhage, where a woman who's delivered a baby just bleeds and dies from that. When that happens within 24 hours of delivery, we call it primary postpartum hemorrhage. If it's anything after 24 hours up to 6 weeks, it's secondary postpartum hemorrhage. So those are the ones. Then the third one would be factors that relate to hypertension in pregnancy. I'd mentioned preeclampsia, eclampsia, and related factors. There is embolism. Well, that would be far-fetched in a place, well, we don't see so much of it in Nigeria or in sub-Saharan Africa. It will be more common in the developed countries. And then we also talk about puerperal sepsis. So sepsis, infection from childbirth, and usually from, just unsafe aseptic practices during delivery. Those are the 5 major ones. So I've talked about abortion, I've talked of primary postpartum hemorrhage, I talked of hypertensive diseases, I talked of infection, and then embolism.
Thank you for helping to structure them in a way that we can relate to properly. I want us to take them one by one and look at them and come up with some very practical cases and suggestions as to how to prevent such things from developing, and in case they still develop, how best to approach them so they don't, end up in death at the end of the day. For example, let's take the issue of abortion. You mentioned 3 areas, which I noted here. The first one has to do with miscarriages, spontaneous abortion. The person didn't probably know anything that she did, but the thing just spontaneously happened, and then it may now culminate in death at the end of the day. It could be that the person had ectopic pregnancy and then eventually led to death. Or it could be that the person attempted to abort the baby and maybe didn't do it correctly, went to the wrong places and the wrong persons. At the end of the day, the woman loses her life. Let's take them one by one. What are the things that can cause spontaneous abortion, for example, in a person? And what should a woman know in order to prevent such a thing from happening to her?
Okay. So spontaneous abortion, we call it random. Like if a woman has a miscarriage, or early, so first trimester loss or second trimester loss of the pregnancy, it's random. You know, if it's 1, by the time a woman is having 2 or 3, then it becomes more of, okay, maybe there are underlying factors. So we kind of find out that if a woman has a miscarriage and you went ahead and did all the tests, you probably won't find any if it's 1. Yeah. Okay. So and so if a woman has a miscarriage, how it happens. Okay, let me tell stories. I think I do better telling stories so that you see how it can be. So this woman comes in, she's had 4 deliveries, and now she has what we call a missed abortion. A missed abortion means that child is dead, but the body is not making any attempts to push it out.
Okay.
So and so the pregnancy would be there, but the child is dead, and that creates a place for infection, particularly when the water has broken. If the water hasn't broken, that's fine. So this woman had missed abortion, the baby was dead, then the water broke, and she really didn't come to hospital. She didn't do much about it until she was really septic. I mean, I remember her as an intern. I was an intern then. I was one of those things. I'm like, so we couldn't save this woman. You know, she came to the best of hospitals. I won't mention the name of hospital. I did my internship in a very good hospital. We did the best we could in terms of antibiotics, but it was too late. She still died from that. So infection is one reason why a woman either miscarriage, either spontaneous, or the person went ahead to do therapeutic abortion. Infection could be one reason why that person dies. Second reason will be bleeding. And so, so she might have bled. So most of the time for people who go do therapeutic abortion, bleeding is a cause, infection is a cause. And thirdly, delaying going for medical attention. So they will bleed or have all that. During medical attention, if they go for quack treatment, damage will be done to organs outside of the uterus. So talking about abortion alone, we want to talk of prevention. It is don't get pregnant, do the things to prevent pregnancy. Then the woman won't die. If you don't, so we talk of family planning, we talk of for people who would believe in whatever methods. Whatever method a woman will believe in, some people do natural methods and they do it well. At least they are trying to prevent pregnancies they cannot take care of, so that it doesn't now become either an ectopic or what, prevent the pregnancy if it's not wanted. Okay. And then if it's a pregnancy that is wanted, for instance, an ectopic pregnancy, I advise any woman, you're pregnant and you found out you're pregnant and you have pain, go seek help quickly. Ectopic pregnancy shouldn't kill. A lot of women have ectopic pregnancy in developed countries. We don't even do surgeries anymore. We do medical. You don't have to open up. If it's caught early, medical treatment, that woman doesn't need surgery. But in back home, the people wait till it's, you know, ruptured and everybody's running all over the place and the woman could die. So prevent the pregnancy or seek help quickly if you have complications of early pregnancy.
Yeah, I will have 2 rider questions on that answer you just gave. One is, I want you to speak to the issue in this part of the world in particular, when a woman, I mean, it's not just related to women alone, but in this case, we're talking ectopic pregnancy, we're talking about spontaneous abortion and pregnancy-related causes of maternal death. Now, a woman is pregnant. She's told that, oh, this is ectopic pregnancy. You need to do something quickly. She says, no, I have been trusting God for this baby for long. I cannot afford to lose this baby. I'm standing in faith. I want to faith it. I want to faith it until it becomes too late and then she dies. You are a minister of the gospel as well as a medical practitioner. I want you to speak to balance those 2 things. That's number 1. The second one I want to ask is, if somebody has this baby that is dead in her womb in the first trimester, maybe it's just 4 weeks or 8 weeks, it's her first pregnancy, she's never had one before, she's not experienced in knowing the signs that she should be having. How does she know that the baby is dead? Particularly for those who don't go to register for antenatal until they are 3 months or 4 months, into the pregnancy. How does a rookie know that, look, this baby could be dead before it becomes too late? What are the signs that a new, expectant mother look for?
So let me start from the second question. Some women will tell you, I felt pregnant before, now I don't feel it. So there are signs that a woman could be pregnant. You've missed your period, and some people feel heaviness, fullness of the breast, or even pain in the breast. They have nausea, they feel like throwing up first thing in the morning, and all those other signs of pregnancy. And then suddenly all that stops. It's a sign to say, let me go check this out, because there's no other way you know. The only way we'll know if a child had stopped is if you knew the child was kicking, and that kicking would come in around about 20 weeks of pregnancy. So before 20 weeks is difficult. There's no other way to know unless you went for medical attention and ultrasound is done, or blood work is done to prove that something was going on. So that's one of the signs. You just feel not pregnant anymore. And I know that's difficult, particularly for women who are looking to get pregnant. When they do get pregnant, it's like, no, they are feeling it. In fact, there's a condition we call pseudo-pregnancy. Pseudo-pregnancy, where a woman is not pregnant, but she feels she's pregnant, and she's just, enjoying the fact that she thinks she's pregnant. So it's difficult. People should go and get tested and to know that.
Sorry, before you answer the second question, how many weeks should a woman be before registering for antenatal?
What we say is that, as soon as you are pregnant, you at least confirm that pregnancy, confirm a normal pregnancy. So it's difficult to say particularly, go. I would tell a woman, once you've missed your period, go get checked out. That's the best. If we want to do consensus, we'll say, okay, within the first 3 months, just, find time to go. But it ranges, right? There's a big range. And particularly for women who are wanting to get pregnant, there's a higher risk of all this stuff for whatever reason. So you feel you're pregnant, go check it out first. And then we'll take it from there. Right.
So the second question now, that's faith and science.
Not only infection that can kill a woman who is losing a first trimester pregnancy, there are also bleeding, we call it bleeding disorders. Okay. So if a woman has a missed abortion, she didn't break her water, she's not exposed to infection, but she keeps having that baby in there, it could affect her clotting factor and bleeding and all that, and then there could be death. So let me just add that. Now, when it comes to faith, I have an interesting way of answering this question, because this is me directly sitting in as a senior registrar in UCH then, and I'm listening to the conversation between one of my house officers or junior registrar talking to a woman who is going to be cared for by us. And so the young man, the doctor is saying, we need you to go and get your people to donate blood. And the answer is, I will not need blood in the name of Jesus. I am not going to need blood in Jesus' name. And the young man says, I know you won't need blood, or you may not need blood. But the way it works here is that we need blood bank for everyone, so that if a woman is bleeding, it could be you, it could be somebody else, there's blood for everybody. I am not going to need blood in the name of Jesus. And she went on and on until myself as a senior registrar, and of course, a minister, even at that time, I had to go to her and say, Madam, I believe with you, you won't need blood. The way it works in this place is you will donate blood for you to make life comfortable for all of us, including you. And I will stand with you. I'm a Christian myself, but the number of people I've seen who, when they come in and they say, I will not need blood, I will not do this, they need it. They are the ones that need it. I said the one who has faith will not make a big noise. People who have faith, while you're saying, go and put blood down, they are telling their Jesus right there that they won't need blood, but to make this system work, we will get people, and if they now need it, then there's blood for her and every other person. Mm-hmm. again, what I went through in UCH then was because people knew I was a minister's wife. If any woman dies and they say, where did this woman labor? And they say church. Of course, I'm the offender. Like, it's almost like a personal issue. They took it up with me so many times. I was so frustrated because it was like, they say, you guys hypnotize women. How can a woman who has looked for children for so long and is a stickler gets pregnant and goes and tries to deliver in a prayer house? She came, the baby was dead. She didn't die, but the baby died. I mean, these are extreme things that we shouldn't be hearing. I tell people faith is in retrospect. If you had faith, it would have worked. If you end up suffering, something was more than, I think many of us do things out of fear rather than faith. That's my conclusion at the end of the day.
Right.
Yeah, so that's my talk to the woman who you need both. I mean, look at developed countries, for instance. They have all these things in place. You could almost talk of medical miracles where God, and I tell people healing and health and being healthy is a God thing. God will use the hospitals. God will use the doctors. God will use miracles. God will use anything he wants to use. He needs us to partner with him. And at the end of the day, they get the result. We shouldn't be having over 1,000 or more maternal mortality ratio per 100,000 live births, and a place where even if you say they are godless or they don't cry on God like we do, to have 10. It doesn't make sense. Something is not right. So I concluded that it's more of a fear thing than faith. Because even our prayers are based on fear rather than faith.
Yeah, it's a very big challenge in Africa in particular. I mean, sub-Saharan Africa specifically, to help people to balance faith with with science. Sometimes they make it look like science and faith are contradictory. I reject it in Jesus' name. It's not my portion in Jesus' name. It's so rampant that sometimes you don't even know where to begin the conversation anymore. People will tell you, I don't want to do this. You ask them why. They say, I just don't want. And that is it. My faith will carry me and all of that. Now, because what concerns me now is the fact that people who are not operating by faith, so-called, they are having only 10 women dying out of 100,000 during childbirth. Those of us who are so prayerful and have a lot of faith, we are having 1,000 women dying out of 100,000. Shouldn't we be asking some questions? Something is missing somewhere. There's a missing link somewhere. And we need to, not sweep these things under the carpet. We need to have a conversation around them so that people can get to know precisely what is right, what is wrong, and then make adjustments where necessary. Thank you for shedding so much light on all of those things, particularly with the very practical examples. Now, you mentioned ectopic pregnancy. I don't want to assume that everybody knows what ectopic pregnancy is. Just in a minute, explain that for us.
Ectopic pregnancy means a pregnancy outside the uterine cavity. So a woman is supposed to get pregnant, and that pregnancy would be developed right inside the cavity. But most of the ectopic pregnancy will happen in the tubes. Most of it. There's some that will be on the ovary or in the abdominal cavity itself, but most of it will be in the tubes. And so when they get bigger, the tube ruptures and then there's bleeding. Yeah.
Okay. So what should a woman with ectopic pregnancy do?
Go to the hospital as fast as possible. That is, there's no other way to deal with it than to not allow that pregnancy to kill that mother. So it's one of the things, even as residents, you have to be on your toes to make that diagnosis and ensure treatment immediately.
All right. Now, we've dealt a little bit with abortion-related maternal deaths, which can be as a result of somebody carrying out abortion incorrectly or with quacks, or it could be ectopic pregnancy, or it could be spontaneous abortion or what have you. Now, the second category you mentioned is hemorrhaging. Of course, these things are overlapping also here and there. Would you like to address other factors that could cause hemorrhaging apart from the ones we have mentioned earlier? Are there any other things?
category on its own. If we want to talk about that, maybe that will take another 15 minutes. It's a category, it's a primary postpartum, which means immediately after delivery. We're now talking of delivery, not abortion.
Okay. All right. Can we spend 5 minutes on that for now? Because our time is almost up. Then in the next episode, hopefully next week, we'll be able to look at the other 3 categories.
Sure. So primary postpartum hemorrhage means a woman who bleeds excessively immediately after birth. It's one of the very common ones. I would imagine it's still possibly the leading cause in Nigeria right now. And from that, there can be various causes of that happening. But anything in excess of 500, usually a woman would bleed like 500 mils of blood after delivery. Normal delivery, if it's cesarean section, we talk about 1 liter. But anything in excess of that falls into that category. Or for some women, they didn't start out right in the first place. They had anemia. And so any amount, even less than 500, could cause reactions in the body. Vital signs crashes, blood pressure goes down, pulse starts raising up, they start shutting down the kidneys. So those are things that now lead to death. That they didn't start out right could mean a lot for women. And quite a number of women, if I remember in the practice those days, would have anemia right up to delivery. So within 24 hours, those ones are dramatic. I've seen women, once the baby came out, the woman could bleed out the whole of her blood in 5 minutes. Wow. Because that's how richly bloody, let me put it that way, the uterus could be when it's pregnant. So we don't want to do stuff on the uterus when it's pregnant, because a lot of blood is flowing through at that time. So there's the most common one will be uterine atony, where ideally when a woman delivers a baby, the uterus is supposed to contract and shut off those heavily loaded blood vessels that are pouring blood into the uterus through the placenta. And when it doesn't contract, then it means those vessels are open and they just keep pouring blood. So uterine atony is, and then of course there are causes of uterine atony, and one of them will be a woman who's had many deliveries, or a woman who had infection during pregnancy and then causes. Sorry, I'm trying to look for the word now. So the woman gets pre-labor rupture of membranes, and then there's infection in the amniotic fluid and in the internal environment of the uterus at that time, and then the uterus wouldn't contract. Also, multiple pregnancies. So if the uterus is overstretched, not any fault of anybody, twins, triplets, they tend to have more of primary postpartum hemorrhage. And then if a woman has had a prolonged labor, they tend to have primary post. So all that, we anticipate that was going to happen. And so there are medications that we don't even wait for the blood to start pouring. Do what we call active management. You are outlooking the fact that this is going to happen and you give the medications. But if the person doesn't deliver in a hospital and there is no active management, that's where the disaster sets in.
Okay. Thank you so very much for these very relevant and useful pieces of information. I hope that women out there and the men in their lives are well informed about how these things work. And I mean, once you're armed with knowledge, with information, you always know what to do when you see the signs and the telltale signs here and there. Thank you very much today, Dr. Kemi Akindele, for availing us of your time on Exposé. We can't go beyond this point because of time, but we will definitely want to have you back next week so we can discuss the other 3 categories out of the 5 factors and causes of maternal mortality. Thank you very much. This is where we draw the curtain today on Exposé. Ladies and gentlemen, don't forget what we need is not more medication, but more education. For the best prescription is knowledge. If you are yet to subscribe to our YouTube channel, this is the right time to do so. Also press the notification bell. And on Facebook, if you are watching us on Facebook, this is the time to like us on Facebook. And share this video with your friends and colleagues and family members so they too can be informed. All of us can work together to prevent preventable death so that our statistics in Africa in particular can be improved at the end of the day, so we too can begin to look like it is out there in the Western world. What would it look like if Nigeria too has such a beautiful statistics of less than 10 people out of 100,000 giving birth that are dying from that? Thank you once again, everyone. Have a beautiful week ahead of you. Bye.
You said you are going to do this and this and this through my life. They are not yet done, so it's not time. And the sickness that seems was going to kill me will just disappear. But if you do not engage your assignment, what will you tell God?
So the things you do triggers off something in heaven, and God responds to the things you do.
So there are things that if God forgets, he becomes unrighteous. And God says, look, I'm too holy to become unrighteous.